Hello everyone and welcome to my talk, The Role of Intraoperative Cholangiography in Gallstone Disease. This presentation was originally presented to faculty at the University of Florida on July 26 and is now being represented virtually for my YouTube audience on August 25th of 2022. Let's get started. The objectives of this talk are to summarize a patient presentation, discuss a patient's perioperative course, ask the audience, review relevant sources, and share my personal conclusion. Patient presents. Mr. L is a 78-year-old male who was in his normal state of health until he presented to the VA hospital with abdominal pain and diarrhea. Mr. L's past medical history was significant for hypertension, peripheral artery disease, bladder cancer status post-chemotherapy, and prostate cancer status post-prostatectomy. His surgical history was notable for no previous abdominal surgeries. He did have a failed left lower extremity bypass reperfusion procedure with vascular surgery and was now status post left below the knee amputation with a prosthesis on. He also had a radical prostatectomy for his prostate cancer as noted previously. Mr. L's social history was notable for being a former smoker and having a history of alcohol abuse. Notably, he cut back drinking in the 1990s and now currently drinks only 2 to 3 drinks per year. Congratulations, Mr. L. Mr. L denied any history of recreational drug use. Mr. L did have a significant family history of heart disease. Both his mother and brother unfortunately died at a young age due to cardiac etiologies. His nephew carried the diagnosis of heart failure at the young age of 24, and his sister had symptomatic coronary artery disease requiring quadruple bypass. Mr. L also endorsed a vague family history of cancer, although could give no further details. Mr. L was taking a blood thinner, Plavix, for his peripheral artery disease. Here is Mr. L's laboratory workup from his initial presentation. I will let the audience come to their own inferences. The reference values for the laboratory work are shown on the right. Okay, audience, pause if you want to keep analyzing the labs and form your own inferences. Mr. L underwent a right upper quadrant ultrasound that showed cholelithiasis, or gallstones, without evidence of cholecystitis or appendicitis, meaning his gallbladder and appendix did not look flamed, or pancreas for that matter, but there were some gallstones, as you can see pictured. Here's a computerized tomography of Mr. L's abdomen and pelvis without intravenous contrast. So going through the scan, you can notice 3 gallstones in Mr. L's gallbladder approaching his common bile duct. Let's run that back once more. So Mr. L was eventually diagnosed with gastroenteritis and suspected gallstone pancreatitis. He was discharged home with instructions to follow up in general surgery clinic, which he did a week later. Since discharge, Mr. L told the general surgeons that he was experiencing still mild intermittent abdominal pain worse with eating. At this time, general surgery recommended that Mr. L undergo preoperative assessment for further evaluation of his left ventricular ejection fraction in the setting of a strong family history of cardiac disease and a personal history of peripheral artery disease. Echocardiography showed left ventricular ejection fraction of 55 to 59%, and it was concluded that Mr. L was a safe candidate for surgery. At this time, shared decision making was employed for booking Mr. L for an elective laparoscopic cholecystectomy for gallstone pancreatitis, with instructions to stop Plavix 5 days prior to the procedure. Intraoperatively, Mr. L underwent an uncomplicated laparoscopic cholecystectomy. However, during common bile duct exploration with choledyscoscopy, there were found 2 6mm soft friable stones, and after multiple attempts with basket retrieval, only fragments of these stones were able to be retrieved. As you can see in this picture during intraoperative cholangiography, you can see a duodenal filling defect. You can see that this banana-shaped common bile duct has its filling defect in the distal portion where it enters the duodenum. This filling defect is secondary to those two 6mm soft friable stones, which were unretrievable. At 9:48 p.m., the decision was made to terminate the common bile duct exploration and to get follow-up liver function test post-op day 1 for assessment of endoscopic retrograde cholangiopancreatography with GI. This picture below shows a Chick-fil-A milkshake that the medical student won in a bet with the PGY3 that the operation's closing time would be at precisely 10:05 p.m. The operation's closing time was precisely at 10:05 p.m. Hence the strawberry milkshake enjoyed by the medical student, Jesse. Here are Mr. L's labs post-operative day 1 before his ERCP with GI. As you can see, his LFTs are persistently elevated, and this is not unexpected after laparoscopic cholecystectomy with common bile duct exploration. Furthermore, the two stones are another reason that the LFTs would be elevated, as the duodenal filling defect was not yet completely relieved. The next day, our good friends at GI performed ERCP on Mr. L, and the two stones were then successfully removed. Below are 4 images showing the removal process, focusing on the area of the papilla in the duodenum. Post-operatively, Mr. L's LFTs remained elevated, but this was unexpected and secondary to the manipulation of the common bile duct in both procedures. After 6 days, Mr. L's LFTs came down very nicely, and he was discharged with recommendations to follow up with general surgery for post-operative evaluation. So now let me ask the audience, how many laparoscopic cholecystectomies will be scheduled for your surgery clinic today? Well, Jones et al. In the 2022 study cited that 1.2 million laparoscopic cholecystectomies are done a year. And the prevalence of common bile duct injury is only 0.06 to 0.3%, but still, in a sample size that large, those complications do happen. And they could happen to your patients. So let's talk about the good in terms of intraoperative cholangiography. Konstantinos et al. In a 2020 study conducted a literature review on 30 articles. They concluded that intraoperative cholangiography reduces morbidity associated with bile duct injury and retained bile duct stones. They also concluded that although intraoperative cholangiography might increase the cost of surgery in the short term, in the long term it may save money if it reduces complications. They also described international differences in intraoperative cholangiography. For instance, in Sweden, it is very common to do intraoperative cholangiography during almost every elective laparoscopic cholecystectomy. However, other literature was not so supportive of intraoperative cholangiography. Kovacs concluded that when comparing intraoperative cholangiography and no intraoperative cholangiography, there was no difference in bile duct injury, retained stone rate, readmission rate, or length of hospital stay. The only difference they found was in length of operating time. They concluded that although intraoperative cholangiography may be indicated in certain scenarios, the evidence is really uncertain. Johnson et al. In 2012 replicated these findings. At 3 years between intraoperative cholangiography and no intraoperative cholangiography, with or without common bile duct exploration in both cohorts, there was no difference in rates of recurrent pancreatitis or other biliary complications. Finally, Benyon et al. In 2002 performed a retrospective cohort study on 200 patients with acute gallstone pancreatitis and compared those who underwent IOC versus no IOC. The only difference they found, again, was in the length of the operating time. But the difference in the length of stay for the inpatient. This difference, though, vanished when controlling for the type of procedure, open versus laparoscopic. Finally, I will leave the audience with my conclusion. My conclusion was inspired by this paper by Srinek et al. And also from a piece of knowledge I learned from my chief resident during my rotation. By the time of graduation, the average general surgery resident performs only 1/2 intraoperative cholangiogram with common bile duct exploration during laparoscopic cholecystectomy. Participating in a IOC with CBD in medical school as a medical student, I have already participated in over 2 times as much as a general surgery resident. I think that's pretty cool. Srinek et al. Looked at the prevalence of intraoperative cholangiogram over 10 years and over 7,000 patients. The author found that while IOC is still steadily being used, it is perhaps going out of style, and currently about 7% of laparoscopic cholecystectomies undergo intraoperative cholangiogram. Finally, my conclusion is that intraoperative cholangiogram is warranted, safe, and of educational benefit in the academic setting. And although it might be used less prevalently now, I think it is still of great educational benefit, and I'm very happy for the opportunity to be part of this procedure and this patient's care. And finally, to emphasize a point of patient-reported outcomes and long-term post-surgical follow-up, I called this patient on post-operative day 27, and he was doing quite well. Thank you for watching my presentation. Here are my references, and as always, go Gators. Thank you.